Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you once again from Tehran. And once again, I have to say I'm so blessed and honored to have the chance to share this educational platform with all of you, with my dear friends and colleagues and experts from all over the world who are kind and generous enough to share what their knowledge is and what they know with all of us and help us obtain better knowledge and understanding in improving our skills and our practice in a daily basis. As you all know, we have started the Hot Seat series from March 2020, where the pandemic starts, and I think I will finish it by the end of 2021. And hopefully in 2022, we all have a chance to join each other again in person meetings and have a chance to communicate. So I hope that the last 80 sessions of the third seasons have been beneficial for all of you. We are in the last 10 part of our Hot Seat series. And today, I have to say, I was waiting for this day for a very long time. And a very talented surgeon, a maxillofacial surgeon, and a very talented clinician, I have to say, it's not a compliment, it's truth, is here with me. Dr. Nelson Leon from Caracas, Venezuela, has accepted to join. Hello, Nelson, and welcome to Hot Seat, my friend.
Hi, how are you, Omid? For me, it's a great honor to be here today. I know the people who is involved in this lecture, the top notch of dentistry. So for me, it's an honor to be invited. Thank you so much for allowing me to be part.
Actually, it's a pleasure.
As you all, we talked some months ago. Unfortunately, the pandemic make this meeting. We need to postpone the meeting, but we are here. So I am so happy and excited to show you our cases and to discuss and talk about.
Thank you so much. I'm pretty sure, me personally, I'm pretty sure I will enjoy every second of this presentation. I'm pretty sure all the audience will have the same feeling as me. And before we start, I have to say the topic that Nelson is going to talk about for us is about orthognathic surgery and how these kind of treatments can change the patient's lives and the lifestyle and everything. So I'm not going to go to the details because I'm pretty sure when he starts, you will get all the points that you need to get. And before also we start the presentation, I 100% recommend you all to check his Instagram page if you want to just feel the excellence in execution by him. And, you know, I have to say Dr. Nelson Leon is an oral maxillofacial surgeon from, as I said, Caracas, Venezuela, and he has a private practice focused in orthognathic surgery, facial aesthetics, dental implants, and bone reconstructions. So Nelson, we are ready from head to toe to hear your amazing presentation. For sure, at the end of it, we will have a good discussion on the topic. You can share your screen and we can enjoy the presentation.
Well, thank you so much again. As you told, I am from Caracas, Venezuela, a beautiful country in South America. I hope to invite you someday to here because we have beautiful things to show to the world. Here, it's very popular. Maybe Venezuela is well known around the world because we have beautiful women. So we have the record Guinness because in 2008, we won the Miss Universe. And we won again the next years. That never happened in the history of this contest. So from the beginning, we have the people, it's really involved with the beauty contest. And this is one of the most televised programs, TV shows in the year. So can you imagine the problem that we have in order to talk about the orthognathic surgery with the patient about related to the aesthetics? We have a huge responsibility in order to take the decisions when we are going to change some things in the face of our patients. So when you receive the patient in the office, all of them have the same questions. This surgery will be painful. This surgery will change my face dramatically. I don't want to be another person. I would like to maintain my identity, you know. So it's really important to take the decisions. So I would like to spend maybe 5 minutes explaining how I take the decisions in order to make the orthognathic surgery. So the first stage, or the first topic, will be the grade of the anomaly. It's not the same to have a patient with a mild dentofacial deformity as her. This is the before. She had a slight mandibular asymmetry, deviation. So she's, I'm going to show deeply this case, but she's a beautiful patient in the before. So I would like to maintain the beauty in the after. I would like just to improve the problem. Which is the problem, or which was the chief complaint of her? The deviation of the mandible. That is possible if the anomaly is mild. But what happens when we have a huge or severe problems? It's not possible to make, at least for me, to make the correction without a dramatical face change. In this case, we recognize the patient because she have a red pigmentation in the left sclera, in the left globe, but it's other person. In fact, she needed to take a new ID card because nobody recognized. Of course, she's happy, but this is the difference. Not all the patient must change dramatically after the surgery. The second topic, of course, the expectation, the patient expectation. For example, I had this patient, beautiful patient. She comes to the office and she told me, yes, I know I have an asymmetric, I feel old, I feel my field looks older, the nasolabial folds are too deep, but please correct everything, but please do not change my gummy smile because that is characteristic in my family and in my face. For me, this is too much of gum exposure, but for her, it's perfect. So, well, we made a new version of herself, improved version of herself, maintaining the gummy smile because she asked about that before surgery. For I prefer to have happy patients than perfect results, because all of the people who will see this lecture, I am sure that they have at least one case with a beautiful result in every topic, implant dentistry or aesthetics or whatever you want. But unfortunately, the patient is not happy because the expectations were not filled. So the expectation is very important. We have the opposite scenario. We have a patient who he told us, I hate my jaw. She suffered bullying in the high school. So he told me, please do whatever you want. If you need to change all my face, it doesn't matter. I would like to make a huge change. Well, other patient who needed a new ID card because we missed two topics. We had a huge dentofacial deformity, and at the same time, the patient is open to receive a huge change. So it's great. And of course, the decision of the clinician, the experience, I think the orthodontic surgery, it's have a huge artistic component. For that reason, every surgeon have the last word in order to take the decision. So, and nowadays, we have a lot of information through our social media, and that could be a double-edged sword, because sometimes it's not the correct information for the patient. For example, I have this patient who comes to the office. She told me, I want a chin implant, a silicone implant, because I hate my fatty neck, and I would like to improve the chin. So I would like to know what the patient wants, but I need to, I would like to be I would like to take the decision how to correct what do you want to improve. Okay? So I told her, the problem is not the fatty neck. The problem is not the lack growth only in the chin. We have a lack growth in the mandible as well. So I proposed to her to make a mandibular advancement and chin advancement, and I bet with her, if you will not get happy after the surgery, I will give you for free the liposuction of the neck, because you don't have their fat. You have their sagging of the soft tissue, because you have a poor growth of your mandible. And this is the before and after. Of course, the patient is happy because we filled her expectation, but we decide the treatment plan. Okay? So this is the average of things that I take in account in order to take the decision. And when we are preparing a patient for orthodontic surgery, this is the by the book way. We need to use orthodontics in order to decompensate the patient, to move the teeth regarding to the bone, and then make the surgery in order to get the MIP, the maximum interdigitation position. After this stage, the patient will be better in order to get a smile design or whatever you want. But this will make changes, of course, in the face. This is the before and after intraorally, and this is the before and after facially. Okay? This kind of patients represent maybe less than 15 or 20% of my consultation. Here in Venezuela, we have a lot of actresses, actors, beauty contest models, and people who unfortunately are leaving to the country. So I need to be faster in order to make the corrections, and I need to change my protocols in order to get a faster recovery, because this kind of surgery, it's associated with a pain, huge pain post-op and large recovery process. Nowadays, we have a great tools, digital tools, in order to communicate with the patient, with the colleagues. But if you don't have the correct, if you don't have the goals clear in your mind, all the digital tools will not work. For that reason, I think first make a great diagnosis and then make a good treatment. It's not possible to do a good treatment if your diagnosis is wrong. For that reason, I would like to start showing how we make the records of our patient. I think it's mandatory nowadays to take pictures. I know dentists who nowadays don't take picture. I think it's mandatory. For that reason, we use frontal view, resting the lips and smiling. Of course, lateral view in the same positions, and 3/4. We add this kind of projection because that gives more naturality in our patient. And some years ago, we started to use the video because the mimetic is so important. Sometimes we have patients who are scared in the consultation of the the patient with gummy smile don't make the correct smiling when the pictures are taken. So in the video, nobody can cheat you. In the video, you will take more information, and that will be complementary with the pictures. So I would like to make just a summary about this, because this is the key in order to understand the dentofacial anomalies. I would like to talk about macroaesthetics, mini-aesthetics, and microaesthetics. I think David Sarber, an orthodontist from the United States, is one of the most authors who explain in easy way what we need to examine during our clinical evaluation. So I'm not going to talk a lot, because we can do 3 days talking about this topic. But the important things for me, in order to understand the dentofacial anomalies, when we have the patient in front of us in the consultation. So the first that we are going to talk is the transverse facial proportions. Of course, it's just like to put a midline over the picture, and to understand if the patient have any asymmetry. It's so simple. And at the same time, the fifth, it's impossible to have a patient with perfect distance between the fifth. But we need to see if their harmony and their fifth. This is the more important here. In the same way, occurs with the vertical proportion. It's not possible to have the same measurements, because nobody is perfect symmetrical. No exists that kind of people. If that people exist, the appearance doesn't look good. So it's just the harmony between. Of course, when we have a huge discrepancy in one of their third, we will see disturbances in the aesthetics and then in the function. So the upper and lower and mid third, the most important for us, because we are a dentist, is the lower third. Of course, we are going to subdivide in upper unit or subunit and lower unit. One of gold standard is to maintain the vertical proportion in between. I mean, the lower subunit must be 2/3, then the upper subunit, that will be 1/3. So with this really easy examples, I would like to show you an asymmetric patient. We made a line dividing the face in 2 parts. So most of you are thinking, yeah, he have the chin deviated, but the asymmetry, it's more than this. We have a deviation of the nose, we have deviation of the chin, we have one ear more projected to the lateral. So this patient is totally asymmetric. So we will not pretend to correct this kind of patient just making a chin surgery. We need to correct a lot of things in order to maintain or to get the harmony in the face. The other topic that it's really important, I recommend, when you have a patient with this, please open your eyes, because something wrong it's happened. When we have a patient with lip incompetence, something is wrong. Could be because the upper lip is short, or like in this case, the upper jaw, it's too big vertically. We have a vertical maxillary excess. For that reason, the patient is not able to close the lips passively, okay? I am not telling you that the upper lip, the lip incompetence, it's equal to orthognathic surgery. No, just when we have lip incompetence, something is wrong. Please make a more deep evaluation of the face of our patient. Take a look. In this case, in the left, she had a maxillary excess, but in the right, the men have a vertical chin excess. So when you see the difference of the subunits, you can see the alteration of the lower third. We talked about this subunit must be 2/3 about of the lower third, but in this, the ratio, it's totally changed. This is maybe 3 times bigger than the upper subunit. For that reason, we are able to understand what happened without any X-ray or CBCT. We can understand the disproportion or the problem in the growth of this phase. The things could be in the opposite scenario. When the patient have a vertical deficiency, we can see some characteristical, some things that can indicate that the patient have a vertical or AP deficiency. If in patient with the gummy smile, we have an excess of growth, when we have patient with a lack growth vertically of the upper and lower jaw, the first characteristic difference will be a lack exposure of the teeth without gummy exposure or gum exposure. And this is really common. In my country, it's really common to see patients with this problem without any treatment for surgical correction. Why? Because this kind of patient, 99% of the time, have a great dental occlusion. The bite is perfect. The canine are in the correct position. The midline are in the same position, but the problem it's vertical. So this patient looks older in the youngest. Okay. We have a lack growth, upper jaw and lower jaw in this case. Lateral evaluation, we're going to see, again, the lip competence. We must to talk with the patient in order to relax the lips. If you see the left and the right picks are totally different position and are totally different, the strain of the muscle of the chin change the treatment plan, at least in my mind. So we need to wait or spend time with our patient during taking the picture in order to relax the lips and take the great records. The same happened when the patient have a mandibular deficiency. The subconscious try to project the mandible forward. And when the patient is class 3 with a big mandibles, it's the same, but in the opposite scenario. We can see the patient, as I show, the left, it's the correction of the head position, but the right is for the patient, the natural head position. It's wrong, of course. In the class 3, happened the same. The left is the position looking a mirror into his eyes in order to correct the position, but the right was that the patient think that is the correct position for him. It's really important to understand the head position of our patient in order to avoid the mask of the problems. In the lateral view, we can see straight profiles, convex profile, and concave profile. All of them have different kind of characteristics in order to be evaluated. Other thing or other tip that we can see during the evaluation is the angles. When we have a nasolabial angle too close, we can see, or we can see maybe the inclination of the upper incisor is too much, or the patient could have a dental alveolar protrusion that will close the angle, or maybe the tip of the nose is dropped. It's just tips in order to see and you will be able to start the facial evaluation. At the same time, the mentolabial angle, if it's too wide or too open, that could be because the lower incisor are inclined to lingually, or the patient have an vertical excess of the chin, okay? What happened in this case? We have a dental alveolar protrusion. The upper lip have too much support. For that reason, when she is smiling, she touch the upper lip with the nose. What happens when we have a maxillary deficiency is the opposite. The nasolabial angle is too open or too wide because the upper lip doesn't have too much support. That's it. In this case, when she smiles, you can see the upper incisor back to the lower incisor. Okay, about main aesthetics, the most important for me is the relationship in the lip, tooth, and gingiva. It's well known, like lip, tooth, gingiva relationship. Like this case, this patient was, colleagues referred this patient in order to make an orthodontic surgery. When I see the patient, take a look. She don't have lip incompetence. And how is the ratio of these crowns are to a square. So this patient perfectly, we can perform a crown lengthening, and that will be perfect for her. She don't have criteria in order to make a maxillary impactation just because you are looking at the gummy smile. Now take a look, this patient. She was referred to me by the smile designer that we are working with them, and he's going to do a digital smile design or veneers, but he needs first to make the vertical correction of her gummy smile. So we made a projection. I don't want to know that this is a digital smile design. I just make the correction of the lengthening of the crown, and take a look. The difference is huge. In the face, 1 millimeter could be the difference between a beautiful or great result or hide the teeth forever. So when you understand which is the goal at the end of the path, you will get there. So in this kind of treatment, our maxillary intrusion need to be less than in the beginning. For that reason, take a look at the difference in the vertical maxillary excess related with the past case. And take a look at this case. Is the height and the width of the crown. Maybe we are able to make a 1 millimeter of crown lengthening, could be, but that will not correct the gummy smile. So this patient must be corrected with a maxillary intrusion. So I show you cases of gummy smile with different approaches because the facial analysis was correct from the beginning. The other thing in aesthetics could be the canting. This is really important, and one tip to check the canting could be the asymmetric gum display. When we see patients showing more gums in one side than other, could be one for maxillary canting, or could be for muscular tract. The traction of the muscle could be asymmetric as well, but this is more common in patients with canting. The black triangles in this area, it's suggestive to maxillary deficiencies. So in this case, we must expand the maxilla and advance the upper jaw in order to fill that black spaces. it's really important to understand the relationship of the midlines, not just inside the mouth. We need to see the patient, all the face of the patient. She understood, sorry, that she had the upper and lower midlines deviated to the right. But unfortunately, her orthodontist didn't see it. So she made with us, we made an orthodontic correction, but the chief complaint of her was the deviation of the upper and lower line. Inside the mouth, it's really important, of course, to see the midlines, as I mentioned. A patient with a class 3 position of the canine guide could be suggestive to a patient with a dentofacial deformity class 3. In the same time with the molar relations. And the class 2 will be the same. Of course, a class 2 canine or molar relation could be suggestive to the class 2 dentofacial deformities. But the most important thing here is to take a look at the overbite. Sometimes the overbite is underestimated, but when we have a patient with a deep bites, with a huge overbites, pay attention, because sometimes the patient could have a mandibular deficiency. So it's really important. Of course, when we see overjet, it's easier for the dentist, the general dentist, to understand that something is wrong in the bite. But this is really common in my country. Patient with a 7 millimeters of overbite, but the patient have porcelain veneers. This is not accepted for me, because the patient didn't know that they needed an orthognatic correction. If after your explanation, the patient don't want to make the correction, is other thing. But how this patient had veneers without the correct bite position. I know in your country it's different, but here is very, very common to see this. And patient with a altered overbite or negative overbite, overbite, we can think that they have a class 3 dentofacial deformities. And just to get the final of this part, the microaesthetics, it's about the phenotype of the gums, the shape of the teeth, the color, if the patient have recessions. This must be evaluated by us in all our patients. I would like to show you some patients, and please help me to make the evaluation with the tools that I give you before. So she comes to my office and she told me this: my nose is too big. Of course, maybe for no trained eyes, the nose looks big. But for me, the problem is in the lower third. It's too back. We have a deficiency. So when I explained that, she allowed to make a correction of the lower third and then make the nose job, because the nose job was decided by her. So this is our evaluation. Take a look in the frontal view. Something is wrong with the inclination of the chin. So we have AP problem and frontal problem. So in this case, it's totally indicated the correction, at least of the chin, at least for me. So we made this correction. Take a look, the three quarters, the face looks convex. So this kind of patient always want to look more definition, the contour of the mandible, the jawline, looks more slimmed. So we made an advanced genioplasty But in the same time, we made a vertical correction, asymmetric vertical correction, descending the left side in order to make more symmetry in her face. This is the surgical pics. This is a really old case. We made right now the approaches maybe 50% smaller with a minimal invasive techniques. We have, take a look, the asymmetric osteotomy. It's really, really ugly, this picture, because the chin looks inclinated. But for me, it's more important to have beautiful faces than beautiful surgical picture, at least in this case. This is the mental nerve. It's preserved. So she asked if it's possible to remove the buccal fat pad in the same surgery. Yes, of course. But I would like to take advantage as well to remove my wisdom tooth in the same surgery. So yes, of course, we can do it all under IV sedation. We remove the third molars. And this is the post-op after 3 days. The worst swelling part was after 48 to 72 hours. But take a look after 21 days. She looks really good. I think when we are delicate and we have a fast recovery protocols, 15 to 21 days are enough to get back to the office, and anybody will notice that you was operated 3 weeks ago. So I am going to show you the before and after. Take a look, the projection of the lower third at the level of this lower subunit. What happened? Why this face is not so beautiful than this face? Because the proportions are altered. This subunit is equal than this subunit. When we made the advance of the chin and descend the left side, we increase the vertical proportion of the lower subunit. It's so simple to understand right now. And we get more symmetry. And the profile, the chin throat length looks better without sagging of the soft tissue. And take a look the difference in the before and after about the projection of the nose. This nose looks totally different here than here. So the job of the plastic surgeon will be different. The decision of the plastic surgeon will be so totally different. This is the post-op after a year. She made the nose job. In this picture, she had maybe 1 month after the nose surgery. This is the before and after. And this is the before and after in 3 quarters, the improvement of the slimmed face. And this is her nowadays. As I mentioned, I like to see the mimetics, the insertion of the muscles, the position, the smile. And for that reason, recording the video is the best way to get that. Okay. The next case. When a patient has a beautiful eyes, the work of the surgeon is almost done. This is really important rule in the surgery field. When she comes to us, the chief complaint of her was just, I would like to show my teeth. I look so older when I smiling. So of course, she is a class 3 patient. Take a look. The important things to evaluate: thinner, too thin the upper lip, nasolabial folds too deep, the tip of the nose drop when she is smiling. But unfortunately, she comes to us We made this evaluation. The mandible is a little bit strong for a delicate face as her. But take a look at the compensation. The upper teeth were proclined and the lower teeth were retroclined, are two lingual. So she had an orthodontist who, in 1 or 2 appointments, she was going to remove the braces, and she felt that her teeth are so ugly. So we changed the orthodontist, made the decompensation, and take a look at the position of the teeth. Looks better. If we are going to do any veneers, a smiley sign, or something like that, will be always better to have the teeth in the correct position, not to compensate with inclinations, because the smiley sign will looks better in this way. So this is our preparation before the surgery, and we made a maxilla operior advancement and a slight left mandibular setback. This is the post-op about Bimax surgery after just 7 days. Again, 21 days. She looks acceptable to come to the office again without any problem, she looks so good for 21 days after the orthognathic surgery. But the final result will be always after 6 months. This is the correction of her chief complaint. She now show her teeth. So, and this, I work here with a lot of aesthetics team, because it's when they started to understand this concept, it's totally different to make digital or a smile design or whatever you want about the aesthetic in this face and this teeth than this. We had a lot of patients that they don't show the teeth, and they made veneers because they wanted to show their teeth. But the operior, it's too back and too high. So in this way, it's really important to make first the orthognathic correction and then the aesthetics. Take a look at the difference. For her, the aesthetics is so important because she is a professional dancer, and she is now really famous in Miami, United States. She appears in TV shows, dancing with singers every week. And this is so important, the stability of our bite. Take a look, the difference. This is the final dental occlusion. This is the frontal view and some picture of her jaw. Okay. Omid, please let me know how time I have, because I have 3 cases more, so I don't know if should I remove one of them. What do you think?
It's fine. We can continue like in 15-20 minutes if it's okay with you.
Okay, I'm going to try to finish in 20 minutes. Great. Well, this patient I showed you at the beginning, she is an actress, really famous here, really talented. So we started to see it in the consultation from 2014, because she was really she never had time to make the surgery, because always she had a lot of TV shows, theater, something like that. This is 2014, 15, 16. She comes to us again, and she told me, I have the time for the recovery. I have 1 month before to appear in the TV show. So in this December, I would like to make the correction, but in January, I need to be ready in order to be in front of the camera again. So, well, okay, 1 month, one month, it's possible to make it. The chief complaint of her was the symmetry, because when you see this kind of patient in the office, it's not too much obvious the asymmetry, but in front of the camera, it's really, really obvious. So the people involved in her job ask why you are moving the mouth to the right, don't do that, because of course they didn't understand the problem from, from the skeletal way. I can show you in these pictures, the deviation to the right, that will change the soft tissues. For that reason, we have more support in one side of the lip than the other. The midline was deviated to the right, just a millimeter. And we made, in this case, we started some years ago to do a minimal invasive surgery. One of the most important things to explain here is the length of the incisions and the dissection. We made 20 to 30 millimeters approaches. It's more than enough in order to make all the surgery, tunneling, everything. When you see the conventional classic way is a huge approach. It's not necessary nowadays. With this, we are able to make all the cuts, and this will change dramatically the post-operative recovery and healing of our patients. So we do this kind of techniques described by Hernandez Alfaro about the twist technique in order to diminish the length of the approach. And then we can see something like that. This is our case. This is the patient after 3 days post-op, upper jaw, lower jaw, and chin surgery. Take a look after 21 days, 6 months, 30 months. It's the same person. We didn't change more than she needed. This is before and after. We try to make the face a little bit longer in order to maintain the younger appearance for a long time. And of course, correct the asymmetry. This is the profile. And take a look. This, how the soft tissues change after the skeletal correction. It's amazing. It's more symmetrical. Okay. This is really popular here. I would like to do veneers. And she have a gummy smile, she have mandibular deficiency. Take a look, she had a Bimax deficiency. Upper and lower jaw are to back. But of course, the chin throat length was too reduced. So we made this kind of correction. She's symmetrical, but the convexity of her face is too much, and she didn't have lateral incisors. It's more complex, this kind of cases, because the aesthetics is too high, and she's beautiful. So we made a counterclockwise rotation of the maxillomandibular complex in order to project, to improve the Bimax advancement, and of course, a slight chin advancement or advanced genioplasty. This was the result. This is the before and after. Take a look at the triangles, the rotation of the face, maintaining the identity of the patient, but the improvement of the face. We made, after the surgery, the dental implants. I don't like to make dental implants in the aesthetic, in the same orthognathic surgery, because I would like to be focused in one miracle at a time. This is the before and after. Inside the mouth, dental occlusion, Bimax, and chin surgery. She's a she works in the TV show, so she's spontaneous to make the videos, the after. I love when I have patients in this way because they feel so confident after the surgery and with her new faces. Okay, I don't want to show my gums when smiling. This is a really common problem as well here in my country. We made the preparation, dental preparation. She had vertical excess, but at the same time, a huge deficiency of mandibular growth. For that reason, the upper jaw looks bigger than should be. Take a look. The overjet maybe 15 millimeters. After the stabilization and preparation, this overjet almost 10 millimeters. We made a technique in order to make a slight setback of the upper jaw and correct the gummy smile. In this case, as I mentioned, nowadays we do not make this kind of approaches. It's not necessary to make this kind of surgery. This is a really old case, maybe 5 or 6 years old. We made a horseshoe osteotomy associated to the level 1 in order to put the maxilla a little bit backward and a huge mandibular advancement. This is the before and after, the bite. So take a look. I'm going to talk about the gingiva tooth and lip relationship again. We understood that the problem was 90% vertical excess and 10% a small crown. So we made this surgery maintaining 1.5 millimeters of gummy smile in order to make then crown lengthening. Because these tooth are too square. So we made this, and this is the final result. After 6 months, this is the before and after. This is a huge smile, and the gum exposure is better, and this is a beautiful side profile. This is the before and after, and I would like to show you this video. I think she's talking about her experience before and after, so enjoy it. Take a look at the fact that she never get makeup in her face, and for the after, I didn't ask her to make this. It's the confidence after the surgery. It's amazing. Okay, the last case. Well, I showed this case at the beginning, so you can notice some things wrong in her face, but the chief complaint of hers, it's about smiling. She told me, I hate when my upper lip touch my nose during smiling. I hate that. I have two nose surgeries, and they didn't correct it. So they didn't correct the problem because the problem is not in the nose. The problem is in the upper jaw. She had a maxillary protrusion, dental alveolar protrusion. So take a look. Something is wrong in the aesthetics because we have a deficiency in this area, but at the same time, the mandible is too strong for a woman. She wanted as well veneers, but she had a slide of gummy smile. But she have an edge-to-edge bite, and she will leave the country after 8 months, so we need to move faster. For that reason, our diagnosis was this: paranasal deficiency, dental alveolar protrusion, and mandibular excess, AP and vertical. So we proposed a segmental osteotomy. We extracted the first premolars in the surgery in order to change the dental alveolar protrusion, but at the same time correct the paranasal deficiency. In this view, we can see how the canine will be together with the second premolar. This do not make too much sense, but in this view, this will be more sense. Take a look. When the canine go backward, the paranasal area go forward. So we will be able to correct with a tailor-made osteotomy for her the both problems, because we have a deficiency here, but at the same time, excess here. So we move a little bit forward maxilla, a slight setback of mandible, and reduce vertically and advance genioplasty. This looks like this, removing the first bicuspid and moving the bone in the direction as I mentioned. This is the frontal surgical view. This is the down fracture. Sorry for the people who don't like the blood. And this is the skeletal or bone stabilization. We made, of course, a reshaping of the nose, the bone, the piriform, in order to increase the airways. In the left, you can see the original bone shape, and this is after the reshaping, and the bone stabilization again. In the mandible, we made the cuts of bilateral sagittal osteotomy, split osteotomy, maintaining the integrity of the nerves. Like you can see the inferior alveolar nerve intact. And this is the before. I would like to stop here, and again, the clinical problems: paranasal deficiency, nasolabial angle too close, mentolabial angle or mentolabial fold too wide, chin too strong for her. I would like to make this face more delicate, but maintaining the identity. So this is just after 3 days. This is the worst swelling for her. Take a look the nasolabial fold. Take a look the mentolabial fold. The change of the chin, just 3 days. And this is her after 21, 3 months, but the final result, 6 months. It's like she looks like the wife of Aladdin for me. She looks so beautiful. Take a look the frontal view. Of course, they made the veneers. The gummy smile disappear. This is the before and after. I prefer to make, in these cases for my patients, of course, porcelain veneers. But in this case, regarding budget problems, she made composite veneers. I don't like it, but she comes, sorry, this is really important. When I took this picture, she told me, well, my facial change was not too much. You're really? Can you think that? So I had this before picture printed in order to make a photo shoot session. So I gave this and I said, please do not see the picture right now. When she saw the picture, this is a natural expression. She forgot how was her face 6 months ago, which is the meaning here. We need to take pictures. We need to make the records of our patient. This is the face. Can you imagine when you make a crown in the second upper molar? Nobody see that, never in their life, and maybe comes to the office 2 months or 3 months. Oh, I don't like it, this crowd or something. You have the records of the pictures. That is really important, really important. Well, she comes to us 3 years later and she changed the veneers. I feel more comfortable with this kind of treatment. This is the before and after. And this is her after 3 years, goes up, moving spontaneously for the video. She is, of course, really happy. She's a makeup artist in United States right now, really famous in Miami. So she's so happy with the result. This is the summary of the treatment. Well, the conclusion of these lectures, all the specialties are connected. So if we have more tools, or if we have more tricks inside the head, we will be able to face every situation in the best way. I would like to say thanks again for this time. First, as I do in all my lectures, I would like to say thanks to God for allowing me to be here in front of you today showing our work. I think every day is a good day to be grateful. Thank you so much, Omid, for inviting me. I feel really, really honored, as I mentioned, because I know your interviews is just for the top-notch dentistry colleagues. So I feel really honored to be here. I would like to say thank to my team, all the people involved in our work. This is our anesthesiologist, and of course, my team of life, my family. I would like to say bye with this: team members never compete. They complement each other. Thank you so much for your kind attention. This is my social media account and my email. If you have any question, I will be here for you. Thank you so much.
Thank you so much, Nelson. I mean, your message was absolutely clear for all of us. And first of all, again, I want to say that your cases, the way of explaining the scenario and the excellencies in your execution is top notch. So hats off to you and your beautiful work. I truly enjoyed it. And as I said, your message was so clear, especially these days that people come to the dental offices looking for a beautiful smile. And as you said, in my country is exactly the same. And I think so many places in the world is the same, that most of the people at the first step, they go with the veneers or ceramics, you know, whatever. You want to change the dimensions, the proportions. And, you know, they don't really think that much comprehensively about the face and how those surgeries can affect the outcome. And one of the things that it was, at least for me, it was really interesting was about the timing. Because one of the issues that most of the patients have in choosing that kind of options in treatments, the surgical approaches, is that they're afraid of time, they're afraid of pain, and they don't know what will happen in the next 3 months, in the next 6 months. And you showed case after case after case, the recoveries in 12 days, in 21 days, in 30 days. And, you know, like in 3 days, there was nothing like, you know, nothing like bruises or changes in, you know, everything. Not that much edema or something. So I think it's a clear message, and definitely not all the surgeons can do the same thing. It takes, I think, skills, teamwork, as you said. It's not easy. And just because someone is a maxillofacial surgeon, it doesn't mean that everybody can do the same thing. We need to have that in mind and respect it, but it's possible. So I think that was a very, very good message that you brought to us, at least from this platform. So for me, it was really, really mind-blowing. So thank you for that. And, you know, You talked about many things. I just want to keep it short because I want to just make some general discussions on the topic. You showed so many of these vertical maxillary excess cases with the complaint of gummy smile and the need for, like crown lengthening or do other approaches like surgical approaches. I want to know in your practice, how many percentage of the cases will end up in the surgical correction? And do you also have in your options like some non-surgical approaches like the Botox or the lip repositioning or some cases like that? Is that your preference to correct it like the way that it should be surgically, or it depends on the demand of the patient?
Yes, this is a hot topic. Great question. Because I think as a surgeon, I would like to do surgery, but the demand of the patient is really important. So I like to hear the patient, but understand the possibilities in every kind of treatment plan. So it's not only to correct the vertical problem. Some of the kite patients, when you are looking the problems, they told you, I don't like the gummy smile, of course, but I feel my face too saggy, or my chin is too back. So if I do the orthodontic surgery, I will be able to correct everything. But in the opposite, I have patient who comes to the office and they told you, I don't want to show my gummy smile and that's it. So we can be more flexible in order to get the final result. But in my office, 90% of this kind of patient comes to the orthodontic surgery in order to correct a lot of things, in order to make the face more slim, in order to correct the gummy smile. Maybe I have great friends who made 80% of their correction, making an intrusion of the teeth with tats or surgical appliances, and it's good. But every patient needs different demands.
Yeah, actually, but as I said, if a patient know that they can make it in 21 days, so the healing process of those procedures is also 21 days. So why not going and fixing everything? So I think that was a good point. And I'm curious about one thing. Actually, I'm a periodontist. I'm not a maxillofacial surgeon, but I'm really curious about those corrections that you make in the mandible. And in parts that you showed, that when you want to advance the mandible and bring it to the front and you cut like the sagittal osteotomies, what will happen to the nerve? Because in some cases you showed completely distraction, the two parts. So I was curious about it, that what will happen to that area? What is the consequences? What is the healing period? So can I have a short, comments on that?
Yeah. Well, we do large mandibular advancements, and in that cases, we put a bone graft between the gaps, but it's not really necessary because the contact of the bone is maintained from the beginning of the cut. It's, as you mentioned, it's a sagittal cut. It's not a vertical cut. So that will start from the lingula, comes to the ramus, and back laterally to the body of the mandible. So we will have always contact. In large advancements, some patient can refer a numbness for more weeks than the normal patient. But nowadays we do minimal invasive surgery. You must to get to extend the invitation for that topic. That lecture is so surgical, and some surgeons love that kind of treatment because the approaches are so reduced. The change of the osteotomy allow us to be far to the nerve. So we made huge mandibular advancements, and the patient have at the next day of the surgery 30 or 40% of the sensitivity intact.
Mm-hmm.
So after 2 or 3 weeks, they will feel 100% of the lower lips. So, and that it's related to the protocols during the surgery and of course the post-op care.
Yeah.
We have a physiotherapy 24 hours after the surgery, infusion pump IV in order to maintain the medication in the house for 2 or 3 days, and of course delicate procedures.
Yeah, yeah. And you know, one more thing that I want to ask you is about that usually in those massive corrections with surgery and orthodontics, you know, sometimes you have like pre-surgical orthodontic phase and sometimes you have a bit of post-surgical orthodontic phase. And in the cases that you showed, you know, for example, you said that the patient have only 1 month or 2 months of time and you want to do everything together. Is those cases also involved in orthodontics pre-surgical and post-surgical, or in those scenarios the time going to be more extended?
Well, our patients are really, really, really weird here in Venezuela because, as I mentioned, we have patients who need to get back to the TV shows or are leaving the country. So for that reason, we have a lot of early surgery patient and surgery first patient. I have, in fact, tomorrow I will perform an orthodontic surgery, and they put the braces 1 week ago.
Mm-hmm.
Why are we are able to do that? We have a digital plan, and the bite allow the stability in order to make a surgery first.
Yeah.
I don't want to maintain the patient 2 years to get there in the OR.
Mm-hmm.
No.
Yeah.
So some things can be fixed after the surgery and will be easier for the orthodontist because you will have all the bones in the correct position and you will be able to understand, oh, I need to move this teeth in this way. In the classic way, they lasted 18 months to go to the operating room. My average treatment of surgery is 4 or 5 months pre-orthodontics. This is early surgery for me. But we have a lot of patients with 1 week or 2 weeks of orthodontics and go to the surgery.
Yeah, yeah.
And that is so good for the patient because they are not waiting too much. They looks better, faster, and they will allow the orthodontic treatment without the pressure to when you are going to remove the braces. I am so exhausted to this treatment. No, because they are focused in the facial change.
Yeah, yeah. Yeah, that was a great message because I think that's one of the questions in many countries. I'm not going to say in all countries, but for many orthodontics and surgeons or general dentists that work with the surgeons and orthodontists that regarding the time, because one of the greatest message of your presentation was that precision in timing, and the cases that you also worked on were not easy people to work with because of the high expectations, and they push you to just do it in the frame of the timing that they have. So my friend Nelson, I have to say, I truly, truly, truly enjoyed having you on Hot Seat. And
thank you so much.
I enjoyed every second of it. I'm pretty sure everybody did. So thank you for accepting. I'm really looking forward to have you soon in my country. You're more than welcome to join us. And I will definitely plan something for you and make this happen.
Thank you.
Thank you so much for your time. And God bless you. And again, hats off for your wonderful work.
It will be my pleasure to be here, to be there. It will be my pleasure. Thank you so much again for this invitation. And I hope to invite you to my country someday.
Thank you so much.
Thank you so much, Omid.
Thank you so much, my friend. Have a good day. Thank you.
Bye-bye.
Bye-bye.